On behalf of the American Heart Association, I would like to welcome you to the first session of today's Pain Management Summit, the evaluation and diagnosis of chest pain. Before we begin, I'd like to quickly review how to use this platform for today's event. If you experience any technical difficulties, most user issues can be resolved by refreshing your browser. If that does not work, please review the system requirements or contact the Zoom webinar helpline. Throughout today's presentation, you will have the opportunity to submit text questions for our presenter using the questions feature on your control panel. You may send in your questions at any time, and we will review the questions during our Q&A at the end as time allows. By email tomorrow, you will receive an invitation to complete our feedback survey. This presentation will be recorded and be made available within coming weeks at heart.org/painmanagement. It's my pleasure to introduce our speaker for today's event, Dr. Martha Gulati. Dr. Gulati is the president of the American Society for Preventive Cardiology. She recently joined Cedars-Sinai Heart Institute as professor of cardiology and is the director of prevention and the associate director of the Barbara Streisand Women's Heart Center and holds the Anita Dan Friedman Endowed Chair in Women's Cardiovascular Medicine and Research. She was a professor of medicine and the inaugural chief of cardiology at the University of Arizona. She also serves as the editor-in-chief of CardioSmart, the patient education arm of the American College of Cardiology, and is the author of the bestseller, Saving Women's Hearts. She served as the chair of the National Chest Pain Guidelines for the American Heart Association and the American College of Cardiology that were released in 2021. Dr. Gulati, the floor is yours.
Thank you, David. And just a minor correction, I'm no longer the CardioSmart editor as of about a year, but I'm still going to share you a little bit about CardioSmart at the end of this. So I'm going to talk about the evaluation and diagnosis of chest pain. And let's see, here's this disclaimer. And then we'll go to the next slide just to show you my disclosures. I don't have any disclosures related to what I am going to be talking about. And I think chest pain is something we see so commonly in any specialty, really in our clinical care. We see chest pain. And I love that this is one of the first descriptions that we are aware of that has been recorded of a description of chest pain. This is by Herbert Den in 1772. And he wrote a really great description. He said, those who are afflicted with it are seized while they're walking, more especially if it be uphill or soon after eating, with a painful and almost disagreeable sensation in the breast, which seems as if it would extinguish life if it were to increase and continue. But the moment they stand still, all this uneasiness vanishes. And he goes on to write further that, he's describing acute coronary syndrome or ischemia. He says if for no accident interferes and the disease goes on to its full height, the patients all suddenly fall down and perish almost immediately. And of course, that was true probably in the 1700s when we didn't have modern treatments. But today we want to recognize when someone is experiencing chest pain that is related to the heart so that we can take care of them because we have a lot of wonderful therapies. So when we wrote the chest pain guidelines, a lot of people, this is, again, something people see. And this was written by not just cardiologists, but emergency room physicians as well, because all of us see chest pain on a regular basis. Chest pain is incredibly common, really at all age groups. We have 6.5 million emergency department visits for chest pain and about 4 million office visits a year. And the interesting thing about chest pain is that most patients don't leave with a diagnosis. In fact, non-specific chest pain, regardless of your age, you can see across the United States, these are the diagnoses, and those blue lines represent non-specific chest pain, and we see them in every age group as the most likely diagnosis. As people get older, it's more likely that it's related to coronary atherosclerosis or acute myocardial infarction, those increase, but there can be many causes of chest pain. And of course, in the emergency room and in our offices, to be honest, we're trying to sort out, is this life-threatening? Is it acute? Is it stable? And is it cardiac as a cardiologist? But for everything, we're also thinking, what are the other causes of chest pain? So, of course, in the emergency room, there is the priorities to identify the life-threatening causes: acute coronary syndrome, aortic dissection, pulmonary embolism, non-vascular syndromes as well. And so, of course, we need to take a history, and those characteristics of the chest pain are incredibly important. And of course, as a cardiologist in the and even in the emergency room, we're always trying to tease out, are these chest pain characteristics cardiac in nature? And there's certain features that might point into the direction that they are more likely to be cardiac. But what my point about this is that the history matters. We have to listen to our patients. Again, we're trying to really sort through it initially about the life-threatening causes again. But there is things that will mimic even these acute chest pain syndromes. For example, think of different things like pericarditis that could be there, rib fracture. These are many different things that can also be presenting as acute chest pain, and that we have to tease out based on our history. So we created top 10 messaging like we do with all our guidelines through the American Heart Association and the American College of Cardiology. And our top 10 messages spell out chest pain. So I'm going to go through those sort of key points and just go through them one by one. So the first point I would make to you is that chest pain is more than pain in the chest. And when we went to write these guidelines, in fact, a lot of our writing group said, do we have to call them the chest pain guidelines? Because it's not always chest pain. And we agree, it's not always chest pain. What it is really for us to try to tease out what the symptoms are and what is the probability of this being ischemia versus other causes. And so our initial assessment when we triage patients is really trying to determine the likelihood that the symptoms might be myocardial ischemia. There's no one magic word a patient will say that makes us clearly know that they're having a heart attack. But there is, a higher probability if they use different words, different terms. But again, there's no one right word. There's things that, people will say that are a lower probability. But, unless there's something obvious, and this, I love this cartoon because we don't take care of vampires, but, if we clearly see the cause, if there's something sticking out of the chest, it's really easy. But to be honest, it's an art for how we'd have to talk to our patients and hear from them what they're experiencing and trying to determine what the cause of their chest pain is. Now, we wanted to also point out in these guidelines that there is certain groups that we have not always identified being at risk in the same way, meaning groups that we really need to pay better attention to. And those three groups are women, the elderly, and people from ethnically diverse backgrounds. I'm going to talk a little bit about women later because we gave them two specific recommendations that I want to focus on. But for elderly patients, again, when they present with symptoms such as shortness of breath or even a fall that, where you diagnose them with syncope or acute delirium, we should be thinking, could this be an acute coronary syndrome, especially when it's unexplained? And that's a class 1 recommendation because the risk of cardiovascular disease is so high at that age. For the ethnically diverse, we do believe that as a class 1 recommendation that cultural competency training is recommended so that we can better understand our patients, better appreciate how they describe things, and understand our patients better who come from different backgrounds, different race and ethnic backgrounds than ourselves. Additionally, we have a class 1 recommendation. When somebody's first language is not English, we should be overcoming language barriers, using formal translation services, not using family members to better appreciate the symptoms that a patient is trying to report to us. Our next recommendation is about high sensitivity cardiac troponins. And we do recommend that we check high sensitivity cardiac troponins if they're available. Now, we know that they're not available yet in every hospital, but where they're available, that's what we should be using. Otherwise, we recommend cardiac troponins in general. That is a class 1 recommendation to identify acute myocardial injury. And we recommend that you understand your own cutoffs at your hospital because for the cardiac troponins, and particularly for high sensitivity cardiac troponins, your 99th percentile is going to be different than even a hospital across the street. It depends on your population. So you do need to know the cutoffs, and you also need to know if you have sex-specific cutoffs in your hospital. We do not recommend checking CKMB or myoglobin for the diagnosis of acute myocardial injury. And we gave that a class 3 recommendation where there is no benefit of using those biomarkers if you're looking for acute coronary syndrome. So our other recommendation is to seek care early for acute symptoms. And of course, we've been trying to get our patients to understand this, to not hesitate to call 911 and to get emergent care. But it also is true when patients present into our office setting. So if somebody presents to your office setting and there's evidence of acute coronary syndrome or other life-threatening cause of acute chest pain, they should be transported emergently to the emergency department, and ideally by EMS. And that's a class 1 recommendation. And another class 1 recommendation is that if a non-cardiac cause is evident, that's a different story. But if that isn't the case, an EKG should be performed in the office setting. And if you can't do an EKG in your office setting, they should go to the emergency department so one can be obtained. And our last recommendation about this is a class 3 recommendation where you can harm a patient. Because if patients with acute chest pain present to the office setting and you're going to wait for cardiac troponins or other blood work to be done, that is not safe. We want to see the patient as quickly as possible and be able to treat them as quickly as possible. So these delays, that's not when we should wait. If you're suspecting acute coronary syndrome, you need to get them to an emergency department. Another question we were asked to answer in the guidelines is how quickly should things be done? So how quickly should an EKG be acquired and reviewed to rule out an ST elevation myocardial infarction? We recommend that that EKG be acquired and reviewed within 10 minutes of arrival. In terms of how quickly cardiac troponins should be measured, it should be done as soon as possible. We just don't have the evidence, and we know that you can make the diagnosis of an ST elevation myocardial infarction without cardiac troponins. The EKG, though, is essential and central to obviously us diagnosing acute coronary syndrome, particularly ST elevation myocardial infarction. In our guidelines, we don't spell out the ST elevation myocardial infarction guidelines. We just say follow them because we were not rewriting them. But of course, our EKG can help us identify pericarditis. It can help us identify non-ST elevation myocardial infarction. It can help us also decide, do we want to do a reverse lead EKG? Do we want to repeat the EKG later? Those are decisions we can make. And of course, if they have an arrhythmia, that may be an underlying cause of their chest pain, or it may be related to, they may have two things going on at the same time. So those are the things why the EKG is certainly central to our care. Additionally, we haven't got rid of the X-ray. The chest X-ray is a class 1 recommendation, and patients do need that as well. The next letter stands for sharing the decision making. And what we mean by that is we have one of the guidelines, all of our guidelines talk about shared decision making and how important it is to involve the patient. But I think what makes our guidelines unique is that we actually have randomized controlled trials showing that shared decision-making tools actually help in the care and the management of our patients. And so we have this recommendation that for patients who present with acute chest pain and suspected acute coronary syndrome, once they've been deemed low risk using a clinical decision pathway, patient decision aids can be beneficial to incorporate shared decision-making, incorporate communication to our patients, and that's a class 1 recommendation. So let me show you where that data comes from. That data comes from using a shared decision-making tool. And this is the shared decision-making tool when we talk in terms that our patients understand. There is randomized control trials showing that patients who were ultimately low risk would understand, okay, I'm out of 100 people, only 2 people might go on to have an event. Okay, I understand I might be low risk. I don't need testing emergently in the emergency department. And patients were better able to understand that and choose to not have additional testing. Additionally, the same investigators went on to show that patients that chose no further testing when they were deemed low risk didn't have worse events. So using shared decision-making tools that our patients can understand, involving them in the process, can mean that our emergency departments can be freed up. Not doing testing in the emergency department doesn't mean no testing. It may mean deferred testing. It may mean do testing later when you talk with your cardiologist or get an appointment with a doctor to review what happened. But it, again, doesn't mean the patient needs to wait there for the testing. So we strongly encourage that these shared decision-making tools be incorporated into our clinical care. And for that point, to go lead on further, is that we say that testing is not routinely needed in low-risk patients. That's because, because patients who are deemed to be low risk are less likely to go on and have cardiac events. But we also defined, what did we mean by low risk? And that means for patients who have acute chest pain and a 30-day risk of death or major adverse cardiovascular events that is less than 1%, that's who we mean are low risk. Those are the patients that do not need testing acutely. They might need testing later on, but they may not need testing in the emergency department. So that leads us to our next recommendation, that we really think that we should be using clinical decision pathways. And you can see that within our guidelines, this is a flow chart right from the guidelines. You know, we say after you obtain a troponin, unless you make a diagnosis, obviously an ST elevation, myocardial infarction up front, if it's possible acute coronary syndrome, use a clinical decision pathway to decide, are they high risk? Are they intermediate risk? Are they low risk? If they're low risk, these are patients that don't need further testing. So clinical decision pathways in the past were called many different things. They were called accelerated diagnostic protocols. They were called disposition pathways. And to be honest, we want to harmonize those different terms. And we wanted to say that let's start calling them clinical decision pathways. You might know them as different things we use in our emergency departments. Will use different ones, and we didn't endorse one over another just because there wasn't enough data to say one is better than another. But you can see there's many clinical decision pathways that are out there. In the United States, the heart pathway is the one that tends to be used most often. But again, all of these have been validated, and they do help us stratify the patient. So again, important to know what your emergency department uses so that you can communicate effectively with them. You might not hear about patients who are low risk because they may discharge them. But you know, when they call us for the other risk patients, we may have a bigger role in the care. And that does help us, as I said, identify the low risk patients and be able to decide whether testing really needs to be done at this point. Now, I promised that we'd talk a little bit about women because I think women specifically have been a group that have often missed. Their symptoms are often dismissed. And so we need to not miss patients that are having potential cardiac events. And that is highly more likely in women because I think for a lot of different reasons. So one thing is that when women present with chest pain, they are at risk for underdiagnosis, and we should think about possible cardiac causes. It should always be a consideration, and that's a class 1 recommendation. That may seem quite obvious, but we felt it needed to be stated so that people just stop dismissing women's symptoms. It's also important to understand that women, you know, chest pain may be there, but they may also have additional or accompanying symptoms. And those symptoms may be more important than the chest pain that they're experiencing. So it's important for us to use the history taking, but also to really understand that women tend to have 3 or more additional symptoms. Chest pain may not be the most important symptom that they experience, and we need to still be listening to our patients. That's what I think has been the problem and why we've missed patients in the past. Our next recommendation is to identify patients most likely to benefit from further testing. And this is really for our intermediate risk patients where we're like, okay, this is possibly an acute coronary syndrome. They are intermediate risk. What do we need to do next? And this, of course, as a cardiologist, this is where it gets interesting for us because we decide what type of testing needs to be done. And, what do we need to do next? Do we incorporate prior testing? Have they had prior testing? If our patients have, we should incorporate that. So, in terms of what we decide to look for, again, we gave class 1 recommendations to anatomical testing, which is the CCTA, but we also gave class 1 recommendations to functional testing. And there will be reasons that you'll choose one over another based on the patient in front of you. But I think that this has really changed our management because in the past, we didn't really have any guidelines that recommended CCTA as first-line testing or anatomic testing. And now we have a lot of new evidence supporting either types of testing. So that's the flow chart for the patients with acute chest pain. We have another one for stable chest pain. And again, you need to decide on the patient in front of you which test you would like to choose. So again, in these guidelines, we had to address acute chest pain as well as stable chest pain, making decisions about what type of testing. But I think I already told you for low risk patients, they don't necessarily need testing, or they may need deferred testing depending on what you want to determine later. But for asymptomatic patients, we don't recommend any testing. That isn't appropriate. And for higher risk patients, you may send them right to the cath lab for those patients, particularly with acute chest pain. So again, the interesting part is the intermediate risk patients where we're trying to work out what's going on. The question we often get is, does my patient need further testing? And it depends on your question, because if you're looking for obstructive coronary disease, the highest likelihood of having obstructive coronary disease is as we get older. So for those people over the age of 70, particularly men, they have a much higher risk of having obstructive coronary disease. But it depends what your question is. If you're thinking other, non-obstructive coronary disease, that might be something else. So, again, depending on your question, that will help you choose the type of test. Whether you want to use a stress testing or CCTA, I told you they're both class 1 recommendations. And so really it'll depend on the individual in front of you. So I like to show this figure because, again, you can see here that, CCTA particularly might be helpful for patients under the age of 65, because if your question is obstructive coronary disease, you'll know it right away. Whereas stress testing, that might be more useful in people over the age of 65 when patients have a higher likelihood of ischemia. But again, at your institutions, your hospitals, your clinics, it depends what you have there too. If you don't have that expertise, you're going to choose the type of testing that you have the expertise at your institution. If they've had prior testing that's been inconclusive, you might choose the other testing. And it's also going to depend on the other questions that you're asking or things about the individual patient that make you choose one over another. So again, the great part is we have lots of options these days. So again, local availability and expertise, characteristics about the patient in front of you, and obviously contraindications. Shared decision-making, of course, is encouraged because the patient may have a preference of one type of testing versus another. Again, for certain types of testing, we can get exercise testing with stress tests, and maybe that's preferred, especially if their symptoms come on specifically when they exercise, or you want that additional exercise information. If you're really trying to assess myocardial blood flow, then you have different choices like a PET scan or cardiac MRI. And again, sometimes you might be able to add on coronary calcium testing to stress testing at certain institutions. So again, you might choose one based on that or based on your own practice. You can see here that, again, when patients can exercise, it can be very helpful, but that always is for certain type of stress imaging where you can do it. If you're specifically looking for quantitative flow, you may not be able to order exercise testing with that. So again, depending on what the patient can do, if they can't exercise, then obviously you'll have to choose accordingly. If you're looking for left ventricular dysfunction or scarring, again, you have different tests. But this is the great part of living in this day and age where we have lots of different choices and we can personalize it for the patient in front of us. We were asked in our guidelines, like all guidelines through the American Heart Association, to think about cost considerations. And it was very hard and challenging for us to do this because we really don't have all studies compared to each other. When we looked at separate trials done where they did show cost effectiveness, it depended on what they were comparing to. For example, you can see here in the CONSERVE trial for CCTA compared itself to direct angiography. Well, it did turn out that that was cost effective. Exercise EKG, there's a load of data that's showing that it is cost effective. So again, I think it was very challenging. You can see here for stress echo, stress MPI, stress CMR, depending on what they compared it to. Yes, there's lots of data showing cost effectiveness, but there's not one saying that there's one perfect test that is not only the best test, but more cost effective than all the others, because we just don't have trials like that. So I'd say that we were not able to answer this question effectively. Test choices, though, for certain groups are important. And I'd say the one group that we really need to consider what type of test choice are women who are pregnant, because of course we want to limit radiation to women who are pregnant. So again, I think thinking about alternative tests first and foremost should be the first step, that, as a safer alternative. But if it's deemed that a test with radiation is necessary, then you need to discuss it, of course, with the patient about the risk versus the benefit, and hopefully that the choice is being made because the benefit outweighs the risk of radiation. And even if you choose a test that has radiation, then the lowest effective dose of radiation should always be used. And I think that's true for all patients, actually, but even more important in our pregnant patients. One of our next letters is about non-cardiac is in, atypical is out. We want the word atypical to no longer be used. This word is used often to convey that the symptoms that a person is experiencing are not different, even though that's the definition, different than what we expect, but rather that they're benign. That is the way that people use that term clinically too often. So we said that chest pain should not be described as atypical because it isn't helpful in determining the cause and can be misinterpreted as benign. We think the better terms we should use are cardiac when we think it's cardiac, non-cardiac when we clearly know it's non-cardiac, and possibly cardiac when we don't know. I think that is better use of the term because it really helps people understand why you're doing additional testing. I'd also like to show you, though, that women and men do experience typical symptoms, if you will, quite a bit. And women, like men, do experience chest pain. So I'm going to just show you some of the data here. So the Virgo study is a study that really shed light on the symptoms that are experienced by young men and young women, so patients under the age of 55. And they actually found that 90% of men and women actually reported chest pain in those who were under the age of 55. The difference between women compared to men is that women reported 3 or more additional accompanying symptoms. So chest pain might not be the most important symptom. What was interesting about Virgo too is that they actually looked at who sought out care for their symptoms before they actually went on to have a cardiac event. And actually more women sought out care for their symptoms before their actual myocardial infarction. But it was women who were more likely to be told that their symptoms were not cardiac. So again, this is all patients in Virgo went on to have a myocardial infarction. Our high stakes group also collected this data. The high stakes group are the people from the UK. They were the ones who really brought us the high sensitivity cardiac troponins. And they also found that 90% of men and 90% of women, again, this is of all ages though, experience symptoms that we would describe as typical. You can see women shown in red on the bullseye and men shown in blue. And actually more women experience the symptoms that we would really associate with myocardial infarction. So again, this is just another example of trying to understand, are we listening to our patients correctly, and why these terms like atypical are not helpful. The ARMY study was also another important study. They used some form of AI, a cardiolinguistic technology. Basically, they listened into the conversation and recorded what they heard between the conversation between the patient and the physician. And what they found is, again, 90% of women and 90% of men did report chest pain. When you remove the bias, the computer was able to record that the patient did experience chest pain. So we really need to start using the language that is good and that matters, and not using terms like atypical that disproportionately are used in women. And it may be, like I said, that we're not listening to our women in the right way. And so lastly, our last letter from chest pains is S, and that structured risk assessment should be used. And we try to show a structured risk assessment within the chest pain guidelines that you can read yourself. I tried to give you a summary version here today, but I think that that really is a good approach and a way to really not miss patients. Within our chest pain guidelines, there is a few new concepts that I did want to highlight. In the past, when we talked about coronary artery disease, often we were referring to 50% stenosis or greater, but we actually said that coronary artery disease starts very early on, and that we included obstructive as well as non-obstructive coronary disease. So the entire spectrum from 1% stenosis all the way to complete obstruction. Also within our guidelines, I would emphasize that we put in a lot of prevention. We put in a lot of focus on guideline-directed medical therapy, particularly in patients who already had known coronary artery disease. So if they had that, the first question should be, before even doing additional testing, are they on guideline-directed medical care? Can you control their chest pain by just getting them on optimal care? And that maybe, is one important part of our guidelines. Just you can see it within this. I'm just going to show you again some of our outline here. We talk about non-obstructive and obstructive coronary disease, but you can see for those patients who have obstructive coronary disease, we already say here, intensify guideline-directed medical therapy and the option to defer testing to see if your guideline-directed medical therapy actually helps the patient. And even when you detect ischemia, even if you choose to go on and do additional testing, our first class 1 recommendation is give them guideline-directed medical therapy. It doesn't mean that everyone goes to the cath lab. Importantly, we talked about non-obstructive disease in the guidelines, and we felt that was important because it really allowed us to talk about ANOCA, or ischemia with no obstructive coronary arteries. That had not been addressed in any of our prior guidelines. And we did give a pathway so that our patients can get additional testing, whether that's by invasive coronary function testing, which we've had some randomized clinical trials that have shown that patients who get this type of testing do go on to have an improvement in their symptoms. But if you don't have that available at your institution, you can still use cardiac imaging, particularly PET and CMR seem to be the ones that we have the most evidence, and that can help us make a diagnosis and target our treatment for patients who have ANOCA with more information than we've ever had in the past, really intensifying our preventative strategies and really guiding our therapy based on their symptoms. So how do our guidelines differ than what was out there? Well, we never had chest pain guidelines for, so they're the first chest pain guidelines, but it allowed us to update randomized trials that had come in the years that we had different guidelines about the evaluation of ischemia, whether that's stable or acute. We also, as you know, I shared with you that we have eliminated certain terminology. The word atypical, I hope you won't use. We also redefined coronary artery disease, that is more than obstructive coronary disease. And that can really help us take care of the entire spectrum of coronary artery disease and address things a lot earlier before it becomes obstructive. I think also our guidelines really give the opportunity for us to eliminate unnecessary testing. Again, that low risk patients, trying to help move patients in the emergency department. Again, this is based on evidence, so we do feel that that is one of the most important things and can allow cost savings. And again, our guidelines really emphasize medical therapy, guideline-directed medical therapy. We've had important trials like the ischemia trial that have shown us that not everybody needs additional testing. That addressing symptoms with guideline-directed medical therapy can really help our patients and have as good of outcomes as sending a patient for going for invasive angiography. There is some gaps and things that we need to work on in the future. Certainly for acute coronary syndrome, they were still trying to always identify ways to reduce the delay from the symptom onset to presentation. There's ongoing work looking at this and looking at patients even treating themselves at home where they're able to transmit EKGs right from their home. We'll see how that works. That's data we're all waiting for. I think the idea that I addressed near the end about ANOCA or ischemia with no obstructive coronary arteries, we need more data. I mean, as much as we can evaluate it, what we need is to know how best to treat these patients. And we are wrapping up the Warrior trial here, in the next 6 months. So we'll actually have a lot more information that can help us with that. I think that, again, I showed you some provocative information about symptom classification. And I think, again, would machine learning help us? Would that help us reduce sex and racial disparities in our assessment and care of acute chest pain? And I think we need to better understand our tools that we've created. Do they really help us identify the right patients who get the right testing? We need to learn more about high sensitivity cardiac troponins in the US population, because we're just at the earliest stages of really understanding how it works in the US population, given that so much of the data came from the United Kingdom. So just in closure, I just want to acknowledge my entire writing group. This is, I had the fortune of being the chair, but this was a team sport. There's a lot of expertise that I could not have done without that really made these guidelines important and helpful and relevant to our care of our patients. And then finally, I just want to let you know the resources we have at AHA.org. We have all kinds of things there, including slides. All the slides I showed you today, almost all of them are there. We have a CardioSmart chest pain hub at the ACC. And we also have things even for our patients that to help them better understand their symptoms as well. We made a lot of apps that are out there, Guidelines Made Simple, guideline clinical apps, interactive app that you can use in your clinical practice as well. And they're all available for free. So thank you so much. And I think that now you may be able to you might have been doing it anyway, but you can submit questions into the chat and we'll be able to take any of your questions.
Thanks so much, Dr. Gulati, for that wonderful presentation. As Dr. Gulati mentioned, we are still accepting questions in our Q&A chat, so feel free to submit them at any time and we'll answer them as time allows. So we've received several great questions so far. So the first series of questions is actually a three-part question from an audience member regarding serum workup for chest pain. So their questions are, where may a clinician refer to when comparing a high sensitivity troponin value to the general population, i.e., are there Z-scores and T-scores available for clinicians to access? What are the indications in drawing a CKMB? And could they draw a CKMB to establish a baseline to compare days after intervention?
So the CKMB, at least for acute coronary syndrome evaluation, we don't feel like it should be done, at least to make the diagnosis. If you want to use a CKMB for other purposes, obviously you can. I think that, you know, interventionalists would probably not really enjoy you just checking it after an intervention, because again, I think that again, symptoms, EKGs matter more at that time than anything that's going on with a biomarker per se. But I appreciate the challenge that exists. But I do think the problem in the past has been people just routinely checking whether it's CKMB or even cardiac troponins after an intervention, and then asking people to act on them despite the fact that the patient is asymptomatic and nothing on the EKG, and taking them back to the cath lab is incredibly costly, but also it would often not serve the appropriate purpose, because again, if something had gone wrong with the stent, again, patients will have symptoms and they will have other changes going on that would really should be the guidance. So for the first question, again, you were saying it was about cardiac troponins. I'm sorry, Kristen, can you read the first part of that question again?
Absolutely. Where may a clinician refer to when comparing a high sensitivity troponin value to the general population, i.e., are there Z-scores and T-scores available for clinicians to access?
Yeah, I think within your laboratory, like I said, we recommend your own laboratory will determine your values for your institution. So that's what you should be comparing things to. You should know your 99th percentile for it's basically based on your population of patients that you're caring for. And that's where they're making the thresholds for. I did want to say that, you know, even, though the high stakes group had shown that sex specific thresholds were incredibly useful, especially for women, for detecting cardiac events in women. It seems that with high sensitivity cardiac troponins, you'll detect more using high sensitivity cardiac troponin. But a lot of institutions have decided not to have sex specific cutoffs despite all that data. So again, talking with your own institution about that, every place is a little bit different. I'd say here at Cedars-Sinai, we're just about to roll out the high sensitivity cardiac troponins, and we've already made the decision that there will be a sex cutoff, so a different value for women than for men. But I had been at another institution where they chose not to. They thought it was going to be too difficult. So I don't know why that is, because, you know, people just look at the labs to say, is it in the normal range or not? But some places will make their own choices on that.
Thank you. Our next question is, when it comes to stress testing and screening for CAD, is exercise always superior to medication induced in ambulatory patients?
Well, I'm a bit biased, so I believe, yes, I believe first physiologic exercise is the best way to stress a patient. I think pharmacologic should be used in patients who can't exercise. And my reasoning for that will be, in addition to the diagnostic part. So, you know, and that means doing truly a symptom limited EKG, meaning or symptom limited stress test, that you don't stop them just because you achieved 85% of their age predicted heart rate, or, you know, because they've gone long enough and your team is bored. You truly make it symptom limited, and that's when you stop it. That's where all our data came from, is from symptom limited EKGs, not stopping at 85% of the age predicted heart rate. And of course, if you are not getting to your targets, whether it's based on heart rate or they don't go long enough, then I mean, you may need to change to pharmacologic testing. But in general, I think exercise reproduces often where patients have symptoms. Additionally, you get prognostic information. There's a lot of important information that you get. Say, if you look at the duration of exercise or the heart rate response or the blood pressure response. So all of the, and as well as the EKG response, of course, all of that information can not only tell us diagnostically what's going on, but prognostically what the risk is as well. And I think that we need to be better about communicating that information in our stress reports. But that's where I find exercise being incredibly important. It says a lot to me. If I have for example, a 55-year-old person who only goes 3 minutes on the treadmill on the Bruce protocol, and versus somebody who's the same age who goes for, I don't know, 13 minutes, very different Met value and very different long-term prognosis.
Thank you very much. Are there any recommendations within the latest guidelines that require resources or technologies not readily available in lower resource settings? And how does this affect equitable patient care?
Yes and no, is my answer. Certainly, we've elevated testing, the type of testing, as I mentioned, that now we do say that, you can use CCTA or anatomic testing. Our guidelines had never really talked about cardiac MR as an evaluation for acute chest pain or even PET scanning. And we did actually. We have more information on these newer technologies, more randomized controlled trials. So when you look at it, you'll be like, okay, well, I don't, maybe in a lower resource setting, you won't have a stress CMR, or you may not have a CCTA, and those may not be options for you. But that's actually why I think that you use what you have in your institution, meaning just because they're all given class 1 recommendation, and of course there's certain places that a cardiac MRI might be more helpful, or a PET scan might be more helpful, for example, for diagnosing ANOCA, for example. But if you don't have them, you can't use them. And so you have to use what's in your environment and what's in your hospital. I think that, again, the good news is we have a lot of new testing and a lot of newer technology, but we also need to admit that not every place has that technology. And certainly I think that we should, if in a lower resource center specifically feels like they need something for a patient that they don't have, hopefully that they have a good referral center where they can get patients this. So an example, again, using ANOCA as an example, that if you did need cardiac MR because you don't have that available, referring those patients to a tertiary center to get further evaluation. I think that's an important thing to consider, because for ANOCA, so many times patients don't get additional testing for this exact reason. And so I think that, again, we need to be able to try to make tertiary centers and the type of testing that we offer at these centers available to patients that are from further. But again, the same barriers will be that they can't necessarily get to a bigger center. So we do need to think about how do we make things more available.
Thank you for your thoughts on that one. Next, we have a question about COVID. So from your experience, has COVID impacted how chest pain is diagnosed?
Absolutely. And so, in the middle of us writing these guidelines, we actually wondered if we needed to start putting in COVID, because of course, as many of you appreciate, people who experienced COVID did have chest pain. The reason we didn't put it into the guidelines is because none of us felt like we were experts at COVID while we were writing these guidelines, because we were all learning about COVID at the time. So certainly in your differential, COVID would be in there, but in terms of the expertise that we had at that moment in time to be able to address them in the guidelines, it just wasn't there. We felt like everybody was writing about COVID, but there was nothing that we really had of substance to be able to put it in the guidelines.
Thank you. For patients experiencing chest pain who perhaps are taking other medications at home, either prescribed or over the counter, such as pain relief, are there any special considerations for those patients when they come into the hospital for their assessment and treatment?
Well, I mean, I think that we're talking about patients who might have, other causes of chest pain and maybe not cardiac, that they might be on medications. Of course, cardiac patients would also be on potential medications like nitrates, but I think we're talking about something else. So I think there's certainly considerations for patients. Obviously, within the differential diagnosis, always will be musculoskeletal pain, and there may be patients that are taking different anti-inflammatories, for example, and then they present with chest pain that maybe has broken through on whatever they're using and needs to be addressed. Of course, depending on the risk factors, we still might think cardiac causes when it's on top of something that they've chronically lived with. But I think that when we think about medications for patients who experience musculoskeletal chest pain, we're always asking them, what are they taking, because of the potential effects, not just on their symptoms, but also on other organ systems. I think I'm a big fan of my patients who have musculoskeletal pain. And if this is an ongoing issue, we highly recommend they take medications like acetaminophen rather than NSAIDs. We have a lot of concerns of patients who take NSAIDs and have bleeding risk that can be associated with that. And particularly if they're already cardiac patients taking aspirin or other antiplatelet agents, we already are increasing their risk for bleeding based on those medications. So, the use of Tylenol or acetaminophen will be more strongly recommended to patients if they have other causes of chronic pain, whether it's chest pain or other joint pain. I'm not sure if I really answered that person's question right, so I apologize.
No, I think that that's what they were asking. Thank you for that. And our final question for today is, I think in relation to the slide you had about ASCVD prevention, both primary and secondary, can you comment on the role of cardiac rehab?
Yes, well, and again, our guidelines were not necessarily, addressing all of that, but I will say once you've made a diagnosis of coronary artery disease, and if they've been symptomatic, or whether you've made the diagnosis of acute coronary syndrome, cardiac rehab is part of our guideline directed therapy. It may not be a medical therapy, but it is a guideline directed therapy. And when people are experiencing ischemia, that should be part of what our evaluation is. One of my first questions I always ask is, by the way, even if we already did, put in a stent a while ago, or we already diagnosed the ischemia a while ago, and they're coming back with chest pain, I'm like, did you go to cardiac rehab? Did you complete cardiac rehab? Because I want to know if they finished their therapy. It's a therapy that we should be giving and using. And these days it's being used less and less, is my feeling. A lot of reasons for that, sometimes accessibility, availability. I know during COVID, a lot of cardiac rehabs had to close for a time with the emergency. And then people sort of got used to not using cardiac rehab. Cardiac rehab is as powerful as any of the medications we use and should be recommended to our patients who are experiencing symptoms of ischemia. It is a covered diagnosis, and it really is something that can benefit the patient. We know we have a lot of data showing that it reduces long-term cardiac events as well as cardiac mortality. And we really underuse it. Only about a quarter of the patients that need it even get referred. And then the number that actually complete cardiac rehab is even smaller. And then if you're a woman is even less likely to be referred to cardiac rehab. So we really need to be thinking about that more. And I'm glad whoever asked that question, I'm actually glad they asked it, because I'm always trying to plug the use of cardiac rehabilitation. Again, we want to prevent patients from going on long-term, having repeat events, and this should be part of our therapy.
Thank you so much, Dr. Gulati, for that wonderful Q&A session. I'll turn it over to my colleague, David, for some messages about how to move on to the next session.
Absolutely, and thank you to the audience for your participation. When you exit the session, a feedback survey will pop up in your browser. You will also receive a follow-up email tomorrow with the survey. The recording from today's summit will be available in the coming weeks at heart.org/pain management. Please be sure to visit the site for additional resources on this topic and to join our mailing list. Coming up next at 12 p.m. Central Standard Time, we have perioperative pain management. To access, please exit the session and return to the lobby using the menu at the top of your screen. From that lobby, click on the Sessions tab first, then click on the individual sessions to join. Thank you very much for attending this summit. We will see you shortly.